Welcome to the Part 1, 1915I Service Authorizations, Medicaid Policy Training. My name is Dawn Pearson. I am the administrator of the 1915I Medicaid State Plan Amendment for Home and Community-Based Behavioral Health Services. I'm with the Medical Services Division of the North Dakota Department of Human Services. Melissa Clockey with the Medical Services Division is also a 1915I administrator. A third 1915I position, a Community Behavioral Health Administrator, is located in the Behavioral Health Division. Part 1 of the Service Authorization Training focuses on the 1915I policy and procedural components of service authorizations. After viewing Part 1, please proceed to Part 2 of the Service Authorization Training by Sarah Regner with the Medical Services. Part 2 will focus on submitting service authorizations in MMIS, which is our Medicaid Management Information System. Part 2 is also available on the 1915I website. What is a service authorization request? A service authorization request is a request from a service provider requesting approval from the state Medicaid agency to provide a service for an eligible member. Following approval from the state Medicaid office, the provider can proceed with providing the service and then later bill the department for the service by submitting a claim. It's helpful to look at a service authorization as the first step in the Medicaid billing and claims process. We chose to break the service authorization and billing and claims trainings into separate trainings as there is much information for both. As 1915I providers, you will serve both traditional Medicaid and Medicaid expansion members. This is included in the provider agreement you signed when enrolling as a 1915I provider. As providers, you will use the process we will train you on today for traditional fee-for-service Medicaid members. This training is not applicable to Medicaid expansion members, and you will use a different process when serving an expansion member. The Managed Care Organization, or MCO, currently Sanford Health, will provide training applicable to Medicaid expansion members. Further information on 1915I for expansion members is available from the MCO website at the link provided. What is MMIS? MMIS is short for Medicaid Management Information System. It is the billing system used by North Dakota Medicaid. The provider enters the service authorization request into MMIS, and the state Medicaid agency reviews and approves valid requests within MMIS. The provider cannot submit a claim for reimbursement for a service provided unless there is an approved service authorization in MMIS. Providers then enter claims into MMIS and the department issues payments. So what is the 1915I service authorization process? The first step following 1915I eligibility determination, the member chooses their care coordination provider. Step number 2, the person-centered plan of care is developed. Step 3, the plan of care identifies the member's needs and goals. Step 4, the service name, amount, frequency, and duration is identified based on the member's needs and goals. Step number 5, the member chooses which provider will deliver the service. Step 6, the care coordinator completes a request for service provider form and sends to each provider identified on the plan of care. Service providers accept the request and inform the care coordinator. The care coordinator submits the plan of care and their service authorization request for the care coordination service via MMIS to the state Medicaid agency for authorization. The state Medicaid agency approves the plan of care, authorizes the service, and informs the care coordinator. Step 10, the care coordinator forwards the approved plan of care to all identified service providers. Step 11, each provider submits a service authorization to the state via MMIS to the state Medicaid agency for authorization. The state Medicaid agency compares the request to the plan of care, the amount, frequency, duration, and approves it. Service providers receive approval. The service provider checks AVRS prior to each service delivery to ensure member is eligible for the 1915I on the day of service. And step 15, the service provision begins. Providers are to call the AVRS number to check individual member 1915I eligibility. The number is provided on the slide, and AVRS is for traditional Medicaid members only. Key points. The care coordinator, in collaboration with the individual, determine the services and amounts, frequency, and duration that each provider will request. The service amount, frequency, and duration requested by the provider in the service authorization request must match the plan of care. The plan of care is then uploaded into MMIS along with the service authorization request. If the service authorization request doesn't match the plan of care, it will be denied. Service authorizations must be received and approved prior to services being initiated for a claim to be paid. Here's a scenario to walk you through how this process will work. Meet Tessa. Tessa is a traditional Medicaid beneficiary with a poverty level of 150% or below, has a qualifying behavioral health diagnosis, and HUDA's score of 50 or above. The Zone 1915I eligibility worker has recently determined Tessa eligible for the 1915I. Tessa has chosen community options and enrolled 1915I provider as her care coordination provider. Tessa and the care coordinator developed the person-centered plan of care. The plan of care is built around Tessa's HUDA's domain scores, which identify her needs. Peer support and employment supports are identified as services to address her needs and assist her with meeting the goals she has identified. The plan of care identifies how much of each service is needed, as well as the frequency and duration. Tessa chooses PATH as her peer support provider and ABC agency as her employment supports provider. The care coordinator completes the request for service provider form and sends to PATH and to ABC, who each accept the referral. At this point, the care coordinator submits a service authorization for the care coordination service in MMIS and uploads the completed plan of care. The state Medicaid office authorizes the care coordination service authorization request in MMIS. This authorization also serves as the state's approval of the plan of care. MMIS generates a letter to TESA and to community options. Upon notification of approval, the care coordinator forwards the approved plan of care to PATH and ABC. The receipt of the approved plan of care triggers PATH and community options to complete their service authorization requests, making certain it matches what is contained in the plan of care. Each of the providers submit the service auth in MMIS and upload the plan of care. The state Medicaid office confirms the request matches the plan of care, authorizes the request in MMIS, and MMIS generates an approval letter to TESA and each of the providers. Care coordination, peer support, and employment support services are delivered to TESA. All providers keep documentation and notes. Each provider submits a claim in MMIS to bill for the services provided. The department issues payments. All services must be delivered in a compliant home and community-based setting. Please view the HCBS Settings Rule training located on the 1915I website. Service limits, rates, and codes. There are service limits, rates, and various codes associated with each 1915I service you will need to be aware of for submitting service authorization requests and also for submitting a claim for reimbursement. As Sarah walks you through the process of submitting a service authorization request in MMIS in Part 2 of the service authorization training, you will see various places where the limits, rates, and codes are utilized. There is a chart included on the 1915I website, which includes the service description, eligible age, rate type, including unit, dollar, or per service, rate type codes, and applicable modifiers, the rate, and the service limit for each of the 1915I services. This slide shows the care coordination service line of the chart. You used many of these codes throughout the provider enrollment process, and you will also use them as you submit service authorizations and claims for reimbursement. Included here is the service description for the care coordination service. Note the description of the service is: coordinates participant care, develops person-centered plan of care, and assists individuals with gaining access to needed 1915I and other services. Each service has a specific definition. A provider will only be paid for those services delivered which fall within the scope definition of the service. If a care coordination provider decides to provide math tutoring to the member, they will not be reimbursed for that, as it doesn't fall within the scope of the service. Again, using care coordination as an example, care coordination is available to members of any age, 0 and on up. Each 1915I service has age limits, which identifies the age of the individuals who can access the service. Again, referencing that chart, the rate type for the care coordination service is per 15 minutes. Other rate types include per service or dollar amount for several of the other services. The code for the Care Coordination Service is H2015. There is no modifier for this service. A modifier is assigned to a rate code, for example, if the service can be provided in a group setting. Family training and supports, for example, can be provided in a group setting or individually. If the service is provided in a group, then the modifier must be identified. The Medicaid fee or rate for care coordination is $20.40 per 15-minute unit. So 1 hour of service equals $81.60 for $20.40 times 4 15-minute units. Each service will have its own rate. Note that the maximum limit for care coordination is 32 units or 8 hours per day. There is no weekly, monthly, or annual limit for care coordination. However, other services may have weekly, monthly, annual, or lifetime limits. Up to 25% of the total care coordination service provided in a calendar month can be delivered through telecommunication. Some services do not have a remote support option, while with peer support, the provider can provide up to 100% of services remotely following an initial face-to-face meeting. The provider type for the 1915I is 049. All 1915I providers use provider type 049. The specialty code for care coordination is 641. Each service has its own specialty code. The group taxonomy code for the care coordination provider group is 251B00000X. Each service has its own group taxonomy assigned. Think of the group taxonomy code as the agency taxonomy code. The individual taxonomy for the care coordination individual provider is 171M00000X. Each type of individual provider has its own taxonomy assigned. The individual taxonomy code represents the employee or the enrolled individual provider who is actually providing the service. All 1915I agency and individual providers will obtain a National Provider ID, or NPI. Instructions on how to obtain the NPI is contained in the 1915I Provider Enrollment Training video and PowerPoint available for your viewing on the 1915I website. Electronic Visit Verification, or EVV. The 21st Century Cures Act mandates that states implement EVV for all Medicaid personal care services and home health services that require an in-home visit by providers. This was effective January 1 of 2021. The 1915I respite service is subject to federal EVV regulations. The individual provider is required to check in and out to confirm their presence in the home. The service authorization and billing processes will be different for the respite service as the THERAP system is used. THERAP will provide training to all 1915I respite providers in the use of EVV. Place of service codes. Medicaid requires 1915I providers to use place of service codes. The place of service codes identify the location a provider delivers the service to a member. The link to the list of place of service codes is located on the 1915I website. When submitting a service authorization request, 1915I providers are required to identify the one place of service code you expect to deliver the majority of the services at. Later, when submitting the claim, the provider is required to list the correct place of service codes for each of the services they provided at any given time and are currently billing for. You will hear more about this in the future billing and claims training. This chart identifies several likely place of service codes a 1915I service would be delivered. These codes shown here are only an example of the larger list called Place of Service Codes for Professional Claims Database, Place of Service Codes, located on the CMS website at the link provided on the next slide. In part 2 of this training, Sarah will walk you through the MMIS screens, and you will see where you will enter the place of service code when entering a service authorization request. A sample scenario for using place of service codes. If you are an enrolled provider of training and supports for unpaid caregivers and anticipate the majority of services will likely be provided in the family home, you would use place of service code 12 for home on the service authorization. However, later when you submit the claim, it's possible you will list 2 or more place of service codes, as it's possible that some of the training and supports for unpaid caregiver services will actually be delivered in the home, which is place of service code 12, or possibly at a school. For example, if the provider accompanies the caregiver to an IEP meeting, that would be place of service code 03. And up to 25% of the services delivered in a given month were provided through a telecommunication system, which is place of service code 02. The correct place of service code must be included on the claim for each service provided. For a complete list of place of service codes, visit the link provided on this slide, and it is also provided on the 1915I website. All right, service authorization process flow scenarios. Please see the service authorization process flow located on the 1915I website for various scenarios impacting service authorizations. You will see process flows for a member's traditional Medicaid eligibility changes to Medicaid expansion, a member's Medicaid expansion eligibility changes to traditional Medicaid, a service authorization request to exceed the maximum service limit, a change in service name, amount, frequency, or duration. Another scenario, a member requests a transfer from one service provider to another. And finally, a member requests a transfer from one care coordination provider to another. The next slides will go through each of these scenarios. So scenario number 1, service authorization requests exceeding the limits. As we discussed earlier, limits were established for each of the services, and service authorization requests should remain within the established limits, as the department's overall 1915I budget was established based on these service limits. However, there is an exception. North Dakota Medicaid will review requests for service authorizations which exceed the maximum service limits in the event the additional service amounts are necessary to prevent the individual from being placed in a higher level of care. For example, an institution or other non-community-based setting. The plan of care must clearly identify the needs of the member which require this additional amount of service. The service authorization process flow available on the 1959 website shows the process the care coordinator and the service provider must follow for requests exceeding the maximum service limits. A change to the services in the plan of care. Whenever a service within the individual's plan of care changes, a new service authorization must be requested. The service authorization process flow located on the 1959 website shows the process that must be used in the event the service name, amount, frequency, or duration changes. In the event a member's traditional Medicaid eligibility changes to Medicaid expansion. If that should happen, the current service authorization is no longer valid. The care coordinator will submit the plan of care to the managed care organization, which is currently Sanford, and the MCO's service authorization process will be implemented. Each provider on the plan of care will need to submit a new service authorization request to the MCO using the MCO's process for expansion members. See the service authorization process flowchart located on the 1959 website for the steps necessary in the event a member's traditional Medicaid changes to Medicaid expansion. And here we have the opposite scenario where a member's Medicaid expansion eligibility changes to traditional Medicaid. Again, see the process flow located on the 1959 website. And you will note a new service authorization is needed in this scenario. A new service authorization would also be needed in the case of a transfer from one care coordination provider to another. There is a process flow on the website that will walk you through the steps. And similar to a care coordination service transfer, this is a member transfers from one service provider to another. And there is a separate process outlined on that process flow on the website that will walk you through that. Okay, in the event a member is placed in a non-compliant setting and the 90-day exception. If an eligible 1915I member is placed in a non-compliant setting, such as an institution, no services can be provided. However, a service authorization can remain valid for up to 90 days if an individual is placed in a non-HCBS setting or an institution and is anticipated to return to the community within 90 days and resume 1915I services. Although no 1915I services can be provided during this time, the individual will not need to be closed from the 1915I nor go through the 1915I eligibility process again, and a new service authorization will not be needed, providing no changes have occurred within that 90-day time frame. In the event the member has a change in living arrangement, which results in the 1915I closing, then the service authorization is no longer valid. For your reference, the Medicaid living arrangement reference hard card is located at this link. If the individual is later determined eligible for the 1915I after being closed, then a new service authorization is required. Confirmation of member eligibility. It is the provider's responsibility to confirm 1915I eligibility prior to providing each service. If 1915I eligibility ends, no services can be provided and the service authorization is no longer valid. Why is it important for the provider to check the member's eligibility? A service provided to someone who isn't eligible is not reimbursable. Providers are to call the AVRS line at this number to check individual traditional Medicaid member eligibility. The AVRS line is for traditional Medicaid only. The managed care organization has a different process to follow for Medicaid expansion members. It is also the provider's responsibility to know if the member is a traditional or expansion member prior to providing each service. If you submit a claim for an expansion member into MMIS, it will be rejected. MMIS must have the service authorization for the traditional member, or MMIS will reject the claim. For verification of Medicaid expansion member eligibility, visit the MCO website at the link provided. 1915I service limit maximums start over on the effective date of the individual's change from traditional Medicaid to expansion and from expansion to traditional Medicaid. All right, we will talk about documentation. North Dakota Medicaid providers are required to keep records that thoroughly document the extent of services rendered to members and billed to North Dakota Medicaid. Records are used by North Dakota Medicaid to determine the service was necessary and to verify that services were billed correctly. Medical records must be in their original or legally reproduced form, which may be electronic. The department is not requiring you to use a certain system for your documentation. Each provider is responsible for their own system and ensuring it meets these requirements. Documentation must support the time spent rendering a service for all time-based codes. Records must be retained for a minimum of 6 years from the date of its creation or the date when it was last in effect, whichever is later. State law may require a longer retention period for some provider types. Please save the North Dakota Medicaid Provider Manual located at this link in your favorites so you can reference it as needed. Medical record valid signature requirements. In order for a signature to be valid, the following criteria is needed. Services that are provided must be authenticated by the author. Signatures shall be handwritten or an electronic signature. Signatures are legible and the signature is dated. Confidentiality and access to expansion member records. All Medicaid member and applicant information and related medical records are confidential. Providers are responsible for maintaining confidentiality of protected health information subject to applicable laws. Providers are required to permit North Dakota Medicaid personnel or authorized agents access to all information concerning any services that may be covered by Medicaid. This access does not require an authorization from the member because the purpose for the disclosure is to carry out treatment, payment, or healthcare operations permitted under the HIPAA privacy rule. Under 45 CFR 164.506. Notice that North Dakota Medicaid and health plans contracting with North Dakota Medicaid, for example, Sanford Health Plan for expansion members, must be allowed access to all information concerning services that may be covered by Medicaid. This access does not require an authorization from the member. Health plans contracting with North Dakota Medicaid must be permitted access to all information relating to Medicaid services reimbursed by the health plan. We are nearing the end. We have a resources slide. Again, I want to bring your attention to the service authorization process flow diagram located on the 1915I website. The 1915I is an amendment to the North Dakota Medicaid State Plan. Thus, all North Dakota Medicaid State Plan provider-related billing and claims policies and regulations also pertain to the 1915I. The General Provider Manual is located at the link provided on the slide. We'd like to remind you to sign up on the website for the mailing list to receive future notifications on the 1915I, and the link is provided on the slide. And we'd like to thank you for viewing this presentation, and please proceed to view Part 2, Service Authorizations, MMIS Training Now. Thank you.